Have you ever wondered why the body forces itself to vomit, even when it's painful and exhausting? So, what's happening under the surface? Vomiting is the forceful expulsion of gastric contents through the mouth, often preceded by nausea. Here's the question. What is the difference between vomiting, regurgitation, and rumination? Vomiting is an active reflex involving nausea, retching, and muscle contraction. Regurgitation, on the other hand, is passive. Food rises effortlessly from the esophagus without nausea. And rumination, that's when swallowed food returns to the mouth and is rechewed, often part of a behavioral condition called rumination syndrome. The vomiting center is a neural network in the medulla. When it's triggered, a coordinated response kicks in: relaxation of the lower esophageal sphincter, contraction of the diaphragm and abdominal muscles, closure of the glottis, and finally, projectile ejection. What actually triggers the act of vomiting? Well, the vomiting reflex can be initiated by signals from almost anywhere in the body. The brain doesn't care where the signal comes from. Once the threshold is reached, the reflex is triggered. Let's break this down. Gastrointestinal triggers include local irritation of the gut. Think gastritis, gastroenteritis, bowel obstruction, or even distension. The GI tract sends signals via the vagus and splanchnic nerves to the brainstem's vomiting center. The nervous system. Elevated intracranial pressure, migraine, trauma, or even vestibular dysfunction like motion sickness can directly stimulate the vomiting center or nearby chemoreceptor zones. Conditions like uremia, diabetic ketoacidosis, or hypercalcemia can alter the blood chemistry. These changes are detected by the chemoreceptor trigger zone, or CTZ, which then signals the vomiting center. Certain drugs like opioids or chemotherapy, toxins, and even intense emotions like anxiety or disgust can also activate the vomiting pathway, either via the CTZ or higher cortical inputs. So in essence, vomiting is a final common reflex. It doesn't matter whether the problem started in the stomach, the brain, the blood, or even the mind. The body coordinates the same response. Amazing, isn't it? To truly understand how we treat vomiting, we need to dive into its neurochemical control. The vomiting reflex is coordinated by multiple brain regions and gut signals, and each uses specific neurotransmitters. Neurokinin 1 or NK1 receptors. They bind substance P, a key neurotransmitter in the final common pathway for emesis. NK1 antagonists like aprepitant and fosaprepitant are especially valuable in chemotherapy-induced nausea. 5-HT3 receptors, located peripherally in the GI tract and centrally in the area postrema and vagal afferents. They respond to gut irritation, such as from chemotherapy or gastroenteritis, and send rapid signals to the brainstem. Ondansetron and granisetron. These 5-HT3 antagonists block the pathway. They are among the first-line agents for postoperative emesis and drug-induced nausea and vomiting. Dopamine D2 receptors are located in the chemoreceptor trigger zone. Chemoreceptor trigger zone is outside the blood-brain barrier, making it exposed to circulating drugs and toxins. That makes it a hot spot for drug-induced vomiting. Metoclopramide, prochlorperazine, and domperidone all block D2 receptors. For motion sickness, the main neurotransmitters involved are acetylcholine and histamine. The vestibular nuclei project to the vomiting center, using M1 muscarinic and H1 histaminergic pathways. That's why scopolamine, an M1 antagonist, is used as a transdermal patch before travel, and antihistamines like meclizine, dimenhydrinate, and promethazine. They're effective for inner ear-related nausea. Cannabinoid or CB1 receptors, found in the brainstem and enteric nervous system. These receptors help regulate emesis, appetite, and nausea perception. Dronabinol and nabilone, synthetic cannabinoids, are used in refractory nausea, especially in chemotherapy or cachexia, when conventional therapies fall short. Now let's shift focus from receptors to motility. In some cases, vomiting isn't just a neural reflex. It is the consequence of impaired gastric movement. That's where prokinetic agents come in. The most well-known is metoclopramide. It enhances gastric emptying and intestinal peristalsis by acting as a dopamine D2 receptor. Domperidone is similar, but unlike metoclopramide, it doesn't significantly enter the brain, so it causes few extrapyramidal side effects. In some patients, we also use erythromycin, a motilin receptor agonist, especially in acute settings to kickstart gastric contractions. Let's continue with chemotherapy-induced nausea, or CINV. One of the most important agents in CINV is dexamethasone. Although its exact mechanism isn't fully understood, it has proven antiemetic effects, especially when combined with NK1 and 5-HT3 antagonists. In patients with anticipatory nausea, where nausea begins even before chemotherapy, benzodiazepines like lorazepam are effective. They reduce anxiety, calm cortical input, and induce mild sedation. I want to close this lecture with a few words about tricyclic antidepressants like amitriptyline and anticonvulsants like gabapentin. In chronic or functional nausea syndromes, such as cyclic vomiting, these agents act by modulating neurotransmitter pathways and reducing neuronal excitability. In the next video, I'll walk you through how to approach nausea in real clinical settings. So don't forget to subscribe to BenMed Academy and stay tuned.